Welcome everybody. I had apparently started it. It said it was waiting to start the broadcast, but it's 12:01. There was one other person I thought would join us. I was kind of waiting till right at 12. But welcome to our Billing Buddies webinar. It the slide up says Chiropractic Medicare Training, but really what we're going to go through today is the LCD for Medicare, but it really applies to just about every payer that you have, with the exception of workers' comp and auto. So if you follow Medicare's guidelines, because they do the correct coding initiatives and medical necessity, if you use their guidelines for all the health insurances, you'd be set. And a little housekeeping on the right side of your toolbar. First of all, there's an orange arrow that pushes it over or opens it up. But there's handouts, and you can click on the handouts to save them that go with this webinar. Also, at the very bottom, there's a chat button. And when we get to the point of being able to ask questions, I ask that you put the question in the chat box there. So that's it. Let's get started. Today, what I'd like to go through is first where to get Medicare's rules for chiropractic services. Second, what the current rules are for ICD-10 for Medicare. And then we're going to review the ABN for when there isn't coverage. I'll use some examples on how to go through that. And then finally, there is in Medicare some of the accident codes, like there was the sprain and strains in the ICD-9. So that anything that started with an 8 or a 9 was a accident. In the ICD-10, anything that starts with an S or a T is, and they require you to tell at what phase of treatment you are in for the 7th digit in those S codes. So I'm going to go through that. And that's what will be real helpful for you for workers' comp or auto too. That it's important to get those codes right. So first of all, where do you find the rules? And you know, with billing, and I'm sure with every specialty, there's so many instances where people will say, well, you know, this is what you need to do, or you need to do X, Y, Z. And I have come to the point where I always verify it with an authoritative authority, such as CMS.gov. And to get what we're doing here is we're going to get the LCD, the local coverage determination. It's thinking here. It's just a minute slow. While it's doing that, I wanted to tell you there's national coverage determinations that the government puts out for kind of a nationwide template, but then each of the carriers for each of the states do a local coverage determination, and they vary. And I'll tell you as we're going through it where they vary quite a bit in just the chiropractic specialty. So I go to CMS.gov, Centers for Medicare Medicaid Services. I type interactive map, and then it brings up a map of what we'll see of all 50 states. View the contractors. So I'm going to pick Minnesota, but whatever state you would be in, you'd want to pick that state. Florida, I say this every time I log in, they pay for extremity adjustments, 98943. That's in their local coverage determination. So you click on your state, and then we're Part B, outpatient is Part B, inpatient's Part A. So we want to click on the link for that. The LCD, I think that I put on the chat bar there for you. I think it says future because that's when I downloaded it last. Here's where it gets confusing for our state anyway. You start wondering if you should log in, and right away we don't have logins, most of us. So we just pick the options. Part B provider, Minnesota, and then remember my choice and accept. Okay, so once you're in here, what you want to do is a medical policy review. Policy center. It seems kind of like a lot of steps, but once you get through, and no, maybe we should give feedback and tell them we don't like all the steps. Okay, so now we can go and you can tell by specialty. And it's alphabetical. Whoops, I went too far. So here's, I need to see the headers. Sorry about that, making everybody dizzy. Okay, so there's part A, which again is hospital, part B, which is outpatient clinics. So they have a LCD if you do hospital chiropractic care, and we want the outpatient one. And now, as you can tell, it's going to throw us back to CMS. And we want to make sure that we say we're not going to sell the codes for the American Medical Association, the CPT codes, and accept that. Now, when you go to here, it brought us to a policy that's been superseded. And so that's strange. That's actually never happened to me. When I go in here, I can get the ones I want. I'm going to go back to advanced search. And I'm just going to type chiropractic and see what I get. Prior to October 1st, the ICD-10 said future. And after that, it should have said current. And we only want the local coverage. This is the second way to search by policy. And then down here we want, and finally we're going to go to national government services. If this doesn't come up, what I will do is go forward with the policy I do have, and then I can email you an updated one. I'll do the research without wasting your time. So this is the active one. We got it. I'm going to print this to PDF. And we'll go off of this one rather than the one I posted says future. I will update it with this as well. They changed the policies, so it's kind of good to know. They make minor adjustments. Certain diagnoses can drop off or be added on. Here it comes. So very good. We got here. I'm kind of an example person. So our first step, we wanted to look at how to get the plan. LCD, as you can tell, it's not always that easy. The next step that we wanted to go through was the current rules and regulations for the LCD. And with this, we'll have a cheat sheet for you on what the provider needs to do, the doctor needs to do, and what the biller needs to do. So let me just kind of throw out an example. Bob is a Medicare patient, and he's shoveling, and he sprains his back, and he comes in for treatment. And so what the rules are is first, this gives us a good guideline. It starts out what meets medical necessity in active treatment, but what's going to come up here shortly is what does it take for charting to get the claim paid. And why that's so important is the claim form that the biller is submitting has to match your medical record. And I will go through that. It's after this area. Sorry for scrolling down so much. Okay, this is it. Okay, so when the patient first comes in, say Bob comes in, this is what they're looking for in your medical record. They're looking for the symptoms, family history. You have all that data collecting when the person first comes in. And the initial visit, as you can see here, requires, I believe there's 6 items. The history as stated above. And then there's the present illness, including all those different items that you need to include. And the part exam, and then included with the part exam, you also need this treatment plan. So you're going to tell Bob, you know, that after you go through the pain, asymmetry, range of motion, tenderness, you're going to, you have to pick a diagnosis that must be a subluxation first, and a symptom second, and then filled by subluxations. I'll show you the on the screen what you have to print out. There's a little cheat sheet for you on one of the screens I'll show you. And then, so you do the initial data treatment today, you do your part exam, you do your initial assessment, and then what they're really looking at, kind of what's behind the scenes that you don't see, is that this date of initial treatment, they're kind of tying that to reasonableness. Is it possible that Bob, who came in from shoveling snow on December 1st, is still in active treatment next June? So it's my belief this is how they pick, you know, when to review things, is if it doesn't seem like, well, Bob can't, you can't show that he's continually getting better, you know, for 7 months, you know, so that you have to be real careful with that date of initial treatment. And then after you do that, there's, here it starts at the bottom of this page, there's subsequent visits, what you need to chart. It didn't download it. I will, you guys, I have your emails and I will send you an updated plan. I think I'm just going to switch to my current plan. So the next step, the doctor, after doing the initial exam, the part exam, the treatment plan, setting the initial date of treatment, it gets passed to the biller. And the biller needs to know what service was performed. I was talking to somebody right before this call, and they said, well, you know, the doctor never bills this 5, you know, he does the 5, but he never bills the 5 regions. And you really need to bill what you did. Your claim form needs to match your medical record. And they've, the government has often posted that, you know, undercoding is just as bad as overcoding. So you really can't do 5 regions and then charge 3 or 4. If your chart got audited, it's miscoded. So first you have to let the biller know what service you performed. And then after you do the services, the next thing we need is a subluxation first. And these are the only 5 subluxations that are covered under our jurisdiction for NGS. There are some I've seen have like 8 different subluxations that are covered, but these are the only ones you can pick from. And of course, the auditor question always is, what if this isn't one of them that they have? Well, then we have to do an ABN. It's not covered if they don't have a covered subluxation. And I'll get to how to fill that out. The second code needs to be a diagnosis that corresponds with this subluxation. So for example, if you have the subluxation in the cervical region, you then need to have a corresponding second diagnosis, the cervical area, to match it. If they didn't have a subluxation, a corresponding symptom, you're back to doing the ABN, because that's what it takes to do medical necessity. That's what they outlined in the beginning. Then the third and fourth subluxations, or third and fourth diagnosis, you want to be subluxations to support the number of areas you adjusted. So if you did 3 areas adjusting, you need to have 3 subluxations down. So make sure you fill those in properly. Let me go back to here. I want to go to our cheat sheet. We kind of did all this. These are the rules we've already done. All those, just looking it up. We're going to look at a sample LCD and doctor's responsibilities, biller's responsibilities. And here's our cheat sheet. So the Bob comes in, you do the initial visit, you do his treatment plan, you have to document a part exam. And on these LCDs, it tells you what they're going to look for if they review your notes, what needs to be on there. Then for subsequent visits, on the notes, and I will get you a good one. It didn't download all the way. It'll have what you need to document for a subsequent visit. So then you pass it off into the biller. The biller needs to put the initial date of treatment on the claim, the primary subluxation and a corresponding symptom, and additional subluxations as they occur. So if you have a 941, you have to put 3 in, obviously, or 4. And then finally, you need the modifier. And this modifier is going to tie back to the diagnosis codes. These diagnosis codes, these are the only covered ones for Medicare. And in the ICD-9 day, when we had like 847.0, if it starts with an 8 or 9, it's an accident. And so accident codes will trigger the insurances to say, hey, what happened? Where'd you fall? Where were you hurt? What? Because they're looking for someone else to pay the bill. In here, the S codes in the T codes, I don't think Medicare has any in here, the T's that they cover, but their S codes and T codes are the injury codes in ICD-10. The tricky part, and this is what everybody's been going around talking about and trying to figure out, is this A, the 7th digit varies. It can be an A for active, D for maintenance, or S for sequela. I have a slide that I can go through with that. And there was a confusing part that came out because for family practice, if you broke your arm and went to family doctor, the A would only be used the first time it was the person was seen. Subsequent times the people were seen would be a D. But for chiropractic, and this is on CMS.gov, sorry about the background noise. I have dogs with me, but they usually are pretty quiet. So at CMS.gov, for chiropractic, A means active treatment. So if the patient is still within the treatment plan and you can show they're actively getting better, you use an A. If the person has reached maintenance level and you can't demonstrate they're getting better, then you use the D, and that's also when we're going to need the GA modifier in the ABN form, which is coming up. These codes, though, what's good to know about those codes, I'm going to go to my next slide with the, is I think I put it at the end here, just a second here. So any codes beginning with an S or T, the 7th digit has to be filled out. A is for active care, D is for maintenance, S is for complications from an injury, sequela is the term, the Latin term, or late effects of an injury. I don't know if you would have that as chiropractic. I don't know if you'd ever be treating a person after an injury that was complicated from the treatment. So, but these are the codes you would use with the accident codes for workers' comp in auto. I'm just going to go back here. And now we're going to go look at the ABN. Now, here's the thing that the clinic prior to I was talking with, the gal said, you know what, we just have everyone sign an ABN. And I actually served for 5 years at the Medicare Provider Education and Training Center. And if you have everyone sign it, it negates all of them. What this ABN form is to give a person, a Medicare beneficiary, education on what is and isn't covered, and have them create and make an informed decision. So for here, for example, Medicare does not pay for D, and you could do maintenance therapy or maintenance adjustments. I like that they put this. Medicare does not pay for everything, even some of the things you and your healthcare provider have good reason to think you need. If it was me presenting this, I would tell the patient, they don't even pay for dentures or hearing aids. So, which would be a good lead-in for why your treatment is necessary. And then you fill it out. This reason Medicare might not pay is the reason Medicare might not pay could be because you don't have a subluxation and a symptom that correspond. Could be that their maintenance therapy So it could be uh, that they've achieved their maximum level improvement. And then here under the estimated costs, you'd put, maybe whatever your services are, approximately 35 to 55 per adjustment, whatever you have that you estimate. And you do not need this, by the way. I see there's a question up. I'll answer the questions in just a second. You do not need this form, by the way, if it's statutorily excluded from the Medicare program, if it's never covered. So, for example, electrical stim, ultrasound, hot pack, that kind of thing is never covered, so you don't need this form. I should caution you. I've seen where you do need to bill for whatever you do. And I do know there's clinics out there that say, well, Medicare doesn't pay for this, so we're just going to give it in for free and throw it in for free. And that's actually really badly viewed as fraud, because it's misappropriating who's paying for services then. If they have Aetna or workers' comp, we're going to bill them this. If they're Medicare, we're going to provide the same service but not bill them. And so that, be really careful with that. Bill uniformly. I had a webinar last week on uniform billing. You might want to check that out if you haven't. Next, they need to pick one of these. They need to say, yes, I want the services and I want Medicare billed. And then, of course, we have the GA modifier. And any of the accident codes would have a D at the end, which means maintenance. Or they need, if they pick option 2, they don't want Medicare billed. Now that's the only option they could pick if you were going to bill them a time of service discount, because you can't carry a balance and have the paperwork incurring and charge them time of service at the same time. Because the whole deal with behind the time of service is, of course, you're getting paid, you're not carrying a balance, you're not doing paperwork. Or option 3 is they do not want the items listed above. So they actually need to make a conscious decision and pick one of those, and then actually sign the form. I'm going to make this a little bit bigger for us. So on the claim form again, and the claim form needs to match the medical record, we have the initial date of treatment, this primary subluxation, and the corresponding symptom to that subluxation, followed by more subluxations if they have it, and then the CPT code in either the AT modifier or the GA modifier if they had signed the ABN and chose option 1 to have the insurance Medicare billed. This, just to carry this Bob story forward. So say you write a treatment plan for 8 weeks, Bob gets better. The treatment date's in here, so December 1st. Come February, unless you think you need to rewrite the treatment plan and you can show continuing improvement, that's when you would do the ABN form and then bill with the GA. Then say Bob in April, he's out fishing and he slips down the bank and he comes back. Well, now you have a new date, initial date of treatment for Bob for April, and a new treatment plan, and you start the process over. So one more review of the essential data: the initial date of treatment the biller needs, diagnosis, subluxation first, corresponding symptoms second, followed by subluxations. And then the CPT codes, these are the only 3 that are covered. So of course 98943 is statutorily excluded from the local coverage determination. So you wouldn't even need to have them sign for that. That's a service that isn't covered by Medicare. And again, that's another one I'll see where providers say, oh, Medicare doesn't cover it, so we just give it to them for free, but we make everyone else pay it for it, and that's where they get in trouble if they get caught doing that. The modifier, the AT, of course, for active treatment, the GA for maintenance care. And finally, we already did this slide, but as you're looking at the diagnosis codes, if you're sending it out in their active treatment, you want an A at the end for the injury S or T codes, a D if it's maintenance, and an S if it's complication. And I think that brings us to the question and answer time. So the question and answer time, I have a question about the ICD-10 codes. And what the ICD-10 codes are is on this policy. And this is where I have found Medicare to be the leading source of how to code and meet medical necessity. If you meet this coding system, you can get the claims paid. And here's the ICD-10 for Medicare that they cover. Now, if it's workers' comp or auto, then you would want to get the accident codes. And I don't know if you've seen this, but when you're at Medicare, I'll show you two different sites. There's two good places to get your ICD-10 codes. So in a nutshell, code your insurance, your Medicare and your insurance as Medicare. And then for your auto and work comp, you make sure you follow that strategy with the 7th digits, because those are going to be accident codes. And there's going to be a lot more accident codes, and I'll show you how to find them. There's a good converter on here too. I'm going to start opening up both. I can't believe it's taken that long. While that's opening, I'm going to see if there's anything else. Any other questions? Here's what I want to show you. If you just type ICD-10, this is a place to look up the codes. And so insurance for Medicare, you follow the Medicare guidelines for all insurances, Blue Cross, Medicaid. They all take the same medical necessity codes that Medicare does. For auto and work comp, if you want to look up a code, a very good source is CMS has a guideline. There's other sources too, because the ICD-10 came from the World Health Organization, so it's public domain, and are free out there, whereas the CPT codes came from the AMA and they're copyrighted. Here's an example. So I just typed sprain, and it gives you the different codes, and here we're back with A, D, and S. That's as complicated as it gets. Once you get your code, you have to say, can I document in my chart this is active treatment and show improvement, or has the person achieved their maximal level of improvement, and then it's a D. The sequela, you'll see throughout here, is if it's related to a prior injury. So sprain of jaw, and they broke their jaw last year, and then they had a surgery and it was complicated. They had scarring, so they that's sequela. I don't know if from a chiropractic standpoint, if you would use that or not. So this is a really good source, cms.gov. Another thing, I'm just going to go back so you can see. There's this free ICD-10 coding reference, and I'm just going to put sprain. So sprain of toxic, if you click on this, I want to show you where it can, you can say it's billable, it was no longer used. So then you can click on the ICD-10. And again, we have the A. Here they are implying that you know to switch from an A if it's active treatment to a D if it's maintenance, or S if it's sequela. Whereas Medicare, I prefer Medicare always, just because I trust the source, I guess. But there's neat tools. It's fun to look at the different things. And there's a converter tool down there, but there's so many new codes. That's not always the best thing. I just think go to the cms.gov and you can look up any of your accident codes for workers' comp or auto and use the Medicare policy to do your billing. Is there any other questions? You know, since I got a couple minutes, I'm just going to tell you a hot topic I'm sorry, I got a different question. Oh, do you leave the XX in? Yes, you leave the X's in the codes. The purpose of those codes are they're fillers, so that they could expand the codes later on. They ran out of digits with ICD-9, and they use these X's as fillers. So yes, you do bill with X's. It doesn't matter if they're caps or lower case either. I wanted to some. And then just real quickly, a hot topic, because we're always in training and there's so many auditors, you know, there's JPEG and ZPICs and all the different audits that they're doing. Generally, the doctors we do billing for are not on the radar because they're smaller practices, and so you don't see it. But I'm always thinking of how to audit proof providers so they don't run into any problems. And one of them is the uniform billing that I talked about as I was talking about different services. Quickly, the rule with the OIG, the Office of Inspector General, which is similar to the IRS, they put out requirements on how providers are supposed to bill uniformly. And what you're supposed to do is, first of all, charge everybody the same, which makes sense. But I mean, it's easy to think, well, I won't charge this Medicare, that person that, or this person that. But you need to charge everyone the same amount and the same everything. You're allowed 2 deviations. You can give a time of service discount if the person indeed pays at the time of service, or the insurance. And I have seen a couple times where insurance is like prepay, like 10 visits if they can get a discount. And so then what the value of that is you're really not carrying a balance, and you know, because you're getting paid today, so the value of money, and you're not doing any paperwork. Now, if somebody came in and forgot their checkbook or doesn't have the credit card, well, now you're carrying a balance and you've got paperwork to do. So you can't give them the time of service discount. That's a sticky one because you kind of develop a rapport with the patients and you want to keep them happy. And when they bring in everything, and they forget one time, you don't want to charge them full rate. The other thing about the time of service discount is the most it should be, and this is right on OIG's website, is a 15% discount. And the reason they consider that's the most savings you could have by getting paid today, and by not doing the paperwork, and by doing more than 15%, they've classified as an inducement for services. So you don't want to give more than the 15%. The other scenario is hardship discounts. And to do that, you need a hardship policy. And the hardship, you need to first figure out what your criteria for your clinic is. And it's open. You can figure this out. Most people are going by the federal poverty guideline that's released on the first of each year. And so you might say if you're under, the federal poverty guideline will do care at, 25%. If you're 200% under the federal poverty guideline, we'll do care at 50%. So you pick your parameters there. And then here's the tricky part. Then you need to verify income. And you need to, as a clinic, establish what that means to you. Do you verify income by tax returns, pay stubs, bank statements? Whatever it is, you've got a method that you're going to verify income. And you can't, otherwise you can't write it off, because you're shifting the burden of payment from that person to the rest of the practice in unjustly so. Okay, if a patient is non-auto with low back pain, which codes would you recommend? Just looking for a quick sample of typical chiropractic patients. Active care. What I would do is, if I would hit these Medicare codes, if these are the ones that they've established aren't going to trigger an accident-related development letter. So if you can get them in here, in this category on this, those are the safest ones to use. If it's a sprain or strain, not being a doctor, if it fit out of the S codes, that's even better, of course. If it's one of these other codes that they have in here. I've always been amazed at billing and follow-up, that all of a sudden I'll see a claim and it's not paid, and it'll say it doesn't meet medical necessity. And I mean, it looks good. It has the initial date of treatment, has the modifier, subluxation, there's a symptom diagnosis. Every single time I get that, these subluxations or symptoms are not on the list. There'll be a gap where that isn't one that they consider medically necessary for treatment. And what can cause that is, if there's some, like fibromyalgia, they think of that as a chronic long-term disease, and you're never going to really get the person rehabilitated. You're kind of stuck there. So same with dementia and mental health. They won't pay for dementia and mental health. Well, obviously, like what would have more critical need than somebody who's going through the loss, of their memory? But because you can't rehabilitate them, it's not covered under the Medicare programs. And that's why some of these codes aren't on this list, and you have to kind of compare it to it. If you're kind of still stuck with coding a little bit, and you're looking for, you were familiar with 739.1, 739.2, 739.3, 739.4, 739.5. That's the codes to have for there. But let me show you one other thing here that I think will help you. There's a converter tool on here. There is at CMS too. There's a nice converter under this ICD-9, ICD-10 converter that you can plug in. So if you know those old codes on the back of your hand, you can go into here and look them up through this converter. I'm just going to do ICD-10 crosswalk. I wonder if that'll do it. I'm going to put it in here too. I'll wait for that to open up. ICD-10 converter. This one here is my favorite one, and it always comes up first. ICD-9 to ICD-10. And you know what? There's a really cool tool at Supercoder that can convert your codes for you. If you're interested in it, email me and I'll tell you what to. I need a spreadsheet from you, but I'll tell you what in what order. Okay, so convert an ICD-9 code. And then down here, 739.1. Let me put the point, no, okay. Convert to ICD-10. There's a general equivalency mapping. The first 3 codes are mapping into certain categories. You'll see that over and over. But here, it'll give you the code right below that. I just want to see 847. Oh, because I remember that was one that Medicare allowed. And then, of course, see it. You need to know that what the 7th digit means, and that's in the slides that you have there. A is active, D is maintenance, S is sequela. So, but that, yeah. So S134XXA. I just want to see something here. If that is one of the covered ones. Yep, that's right at the top. So that was one that Medicare's always recognized isn't accident related, even though it's in the accident category. I have a question. Where can you find up-to-date procedure codes on the internet? So here, this is a great question. First of all, when you deal with the ICD-10, the World Health puts that out, and it's public domain. Anybody can get it, use it, share it, copy it. When you go through CPT codes, procedure codes, now you're into the AMA owns those, and they're copyrighted. That's why every time you go into Medicare or Blue Cross's website, there's that pesky, you have to accept you're not going to sell their copyrighted codes. So the question, where can I find up-to-date procedure codes on the internet, is you buy a book is what you do. But sometimes you get lucky with policies. I have problems with Medicare rejecting claims. Now, Medicare only pays these. Medicare will only pay, let me go up here. for these 3 codes for chiropractic. Now, if you were a durable medical equipment provider and you had a separate DME contract, and that's pretty extensive. They do a site review and they tell you what DMEs you're allowed to provide. Then you would bill a different provider. You'd be billing DME instead of NGS Medicare. There's a DME, I think it's DMERC for our area, but you can't bill durable medical to Medicare. The only codes Medicare you can bill is 40, 41, and 42. And here's kind of how I start. If I'm going to try to figure out how to get somebody to pay something, what I do is go here and say, like I'm going to say lumbar support. And I start trying to find different things. This looks like they're just going to want to try to sell me something. So then I'm going to do lumbar support CPT code and see if I get lucky. Sometimes you'll hit like Blue Crosses. Oh, here, find a code. It's under find a code. That's pretty neat. I wonder if you get a disclaimer you can't copyright it or... The bigger issue though is if you're licensed and credentialed as a chiropractor and not a durable medical equipment provider, that's why a lot of these insurances aren't paying those services. So find a code. That's your answer. Is there any other questions before I sign off? Make sure your claim form matches your medical record. That's kind of like a mantra. Have a uniform pricing model for your clinic. If you think of anything else, just email me. I'd be happy to help you. Or Linda's called me a few times, and I see Kevin's on here. I'd love to help either one of you. So just let me know. And with that, let's see, I've got one more question possibly. Oh, thank you. Oh, wait, there's one other question. Should I not place this on the ledger and billing software with Metasoft? Delete from the claim. Or Linda, make a cash case in Metasoft and put that in there. Make that one cash. In your covered services, put in the Medicare or whatever one you have. You can't technically ever give a write-off if you feel like it, ever. What they look at it is you're misappropriating funds. That if you're deciding this guy doesn't have to pay and your practice has to function, then someone else is paying for that person. And they're really strict on that. I think luckily, from the most part, not all, but everyone, almost all, hasn't gotten audited. But I always, when I learn stuff, we get continuing ed credits. Everyone in our organization is certified, a certified medical reimbursement specialist. We need 15 hours of training each year to maintain our certification. So I always put that out there and try to keep everybody in compliance, just to be kind of protective of everyone. But thank you so much for joining us today. I really appreciate it. Email me with any questions or anything, and I'd love to help you out. And you have a great rest of your day. Take care. Bye-bye.